Good morning, and thank you for joining us for the ACOs versus direct contracting. We're here to talk to you about the pros and cons of each model. With me, I have three esteemed panelists. Before I begin the introduction, I'd like to just take a moment and talk about the fact that this is part of FLACO's virtual conference, and so this session has been pre-recorded and is being played back at a time slot during the conference agenda. Even though the session has been pre-recorded, the panel members are currently available to respond in real time using the chat box feature on your screen. So please know that there'll be no dedicated Q&A at the end of this session. Instead, if you have a question at any time during this discussion, please type it into the chat box and send it to us, and we'll all respond back accordingly. So I'm going to go ahead and begin and introduce our panel. So with me, we have Rachel Corbett, and Rachel is the Vice President of Operations for Aegis Medical Group, and she's also the Executive Director for Primary Care Alliance. She oversees group's operations, which manages approximately 35,000 Medicare and Medicare Advantage members across multiple risk contracts, including Next Generation ACO. She helped build a preferred provider network through the Next Generation ACO program of about 150 organizations to promote and achieve the quadruple aim. I also have with me Dr. Deligish, who's the Chief Medical Officer at Omni Healthcare and also the Chief Medical Officer of Oncology Resource Networks. Dr. Deligish is a board-certified internal medicine, medical oncology, and hematology. And Dr. Deligish completed a fellowship in medical oncology at the Dana-Farber Cancer Institute, a fellowship in hematology at the Brigham and Women's Hospital, and a clinical fellow. And he was also a clinical fellow in medicine at Harvard Medical School. And then our last panelist, Dr. Mark Gwynn, is President and Executive Medical Director of University of North Carolina Health Alliance. He is family physician and experienced physician executive overseeing University of North Carolina's clinically integrated network, their Next Generation ACO, and Population Health Services organization. And as president, Dr. Gwynn leads a statewide integrated network of over 6,000 employed and independent providers, 12 hospitals, and 30 post-acute providers managing patients across risk contracts and multiple payer segments. And Dr. Gwynn has built and scaled interdisciplinary population health services to support and coordinate care for high-risk patients, engage communities to address social drivers of health, and employ quality improvement principles to develop actionable data and analytics solutions. So you are going to have a great panel to have this discussion and help determine which model is best for you. So to begin, and my name is Sheila Fusay, and I'm Senior Vice President with Navis Healthcare, and I have experience participating in the ACO models and many different types of alternative payment models. And I'm going to start off first with a direct contracting overview and talk about some of the basics of the model and how it works. So direct contracting is a new alternative payment model, which is really the next iteration of the Next Generation ACO model that is retiring. And it offers a new risk-sharing arrangements with both capitated and partially capitated population-based payments, so heading towards CMS's goal of moving away from the traditional fee-for-service payments. And there are three different, and with these risk-sharing arrangements, they offer different levels of arrangements, similar to the new Pathways for Success model that CMS rolled out a few years ago for the ACOs, where there's the basic and enhanced tracks that you choose from. That's really how they've structured direct contracting, and we'll go into that a little bit deeper. And they offer three types of direct contracting entrants. So you have your standard direct contracting entrants, or DCEs, new entrants, and high needs. So your standards are groups that have experience serving Medicare fee-for-service patients. So for example, it could be an ACO that's now moving into direct contracting. New entrants are groups that have not traditionally provided services to a Medicare fee-for-service population. And then you also have the high needs DCE. We're really going to be focusing on the standard DCE model for this discussion. Now, continuing with the overview, we'll talk a little bit about the two types of participation and then also the risk options. So CMS right now is launching this model with two, the professional and global, and then they have introduced a proposed geographic model as well that's going to be the highest level of risk. And looking at the progression of risk, you can start in the professional model, and that participation is a 50% shared savings and a 50% shared loss. It's structured with your standard participants, and you can also have preferred providers that are participating as well. And preferred providers are those that are not used to align beneficiaries. They can elect to accept a negotiated payment arrangement from the direct contracting entity, and they have the option to participate in benefit enhancements and patient incentive waivers. So that's, and in a professional model, everybody must take a 7% primary care capitation payment, which is the total cost of care for the enhanced primary care services. The other option for direct contracting entrants is to go into the global model. The global model is going to have 100% shared savings and 100% risk. And you have your choice of either participating where 100% total care capitation, or you can choose the primary care capitation at 7%. And again, it's going to be structured the same way with your participants and preferred providers. And then if you have a comparison, on the lower side of risks, you have your basic track ACO, which you have a 50% shared savings rate, and the loss rate is going to vary. And on the higher end of the MSSP ACOs, you have the enhanced track ACO with a 75% shared savings rate and 15% max loss rate. So the direct contracting is most similar to the next generation ACO, but that program is not open for new applicants. So that's the reason why we're not going to focus on that for our discussions today. So the first thing we'll talk about are the provider relationships, where you have the participant providers, again, that's going to use to align beneficiaries, is going to require quality reporting, and are required to accept the payments from the DCE. And then you have the preferred providers where they can participate to be able to be eligible to receive shared savings and utilize the waivers and benefit enhancements, but they do not have beneficiaries aligned to them. And they can choose whether or not to accept payments through the DCE through a negotiated payment arrangement. So let's start off the panel discussion and start with Dr. Delikish. And let's start with you and ask, what do you see as the top benefit of preferred providers?
Well, I think I would answer that by saying each Medicare direct entity is a little bit different, or Medicare contracted entity. So there's a tremendous amount of flexibility in the program. And as we viewed it, building a network of participating providers or preferred providers allowed physicians to work more closely to coordinate care more closely with primary care physicians and hospitals. And it also allowed those physicians to potentially contract in ways that would generate enhanced referrals to them. So I think potentially for participant providers as opposed to, or preferred providers as opposed to specialists that may or may not have contracted with an ACO or been participants in ACO, as many ACOs were limited to only primary care physicians, being a participant provider allows a physician to coordinate care more effectively, to potentially participate in shared savings in an upside, on the upside, or potentially simply reduce their compensation from Medicare in exchange for increasing the volume of their referrals. So I think there are a variety of potential benefits for participating providers, but it's very dependent on the entity who is determining whether or not they are going to participate in some of the benefits or simply just receive enhanced referrals.
Okay, great, thank you. Rachel, what do you think are some of the top benefits of preferred providers?
I think when it comes to coordination of care, having a contractual agreement around payment opportunities allows the relationship to be developed with those preferred providers to coordinate care and ensure that the proper care setting is available to the patient.
Great. And Dr. Gwynn, what would you like to add for benefits?
Yeah, I agree. I think this is really about developing good coordinated relationships and what we often call medical neighborhoods between primary care providers and specialists. And in general, this is fairly similar to what we've experienced in the next gen model with participating providers and preferred. And this has really allowed us to pull and to bring in specialists and other types of care providers that, as Dr. Deligish mentioned earlier, typically wouldn't have been involved deeply in an ACO. And so this is a mechanism to do that and to help coordinate care better, to develop care pathways, for example, or care contracts or compacts across the network. The fact that preferred providers can participate in shared savings, I think, is highly beneficial. And if the direct contracting entity or the ACO has that aspect of their shared savings policy, then that's really beneficial too. So there's a little bit of financial benefit, but this is really more about stickiness and coordination of care. We've also used this, CMS considers APPs as attributable providers almost regardless of where they practice. And many of our practices, specialty practices, have APPs working there who primarily work in a specialty and not in primary care. So we really use that also to help avoid attribution where it could be harmful.
Right, well, thank you. All excellent points. Really thinking about it from coordination of care to being able to share in the savings, and then also to be able to have correct attribution as well. So the other thing that CMS is testing with these capitated payment mechanisms and advanced payments in the direct contracting model is CMS has a thesis. And their thesis around this is that having control of the flow of funds with their downstream providers and suppliers will enable the DCEs to improve care coordination and delivery and to better manage the health needs of their aligned population, resulting in reduced costs and better outcomes. In the first year, participants can choose up to 1 to 5% of the primary care capitation put up front, and it's going to be reduced from the participants. Again, this would be the participants versus the preferred providers. And then in the subsequent years, that amount increases. So CMS is definitely changing the flow of funds with this. So now what I'd like to do is kind of move the question to about this kind of thesis and the capitated payment mechanisms and some considerations around that. So Rachel, when you were applying for direct contracting and from your experience in next-gen ACOs, how do you operationally manage capitated payments and or fund flows? And what advice would you offer somebody coming into this program?
I think it's necessary to understand the market that you're in to determine if capitated payments will work for the providers or how that capitated arrangement may kind of be determined for each direct contracting entity. Some providers may think it as a positive, some may think it as a negative. You'll have to be somewhat creative on your payment arrangements to ensure that you're getting a robust network to basically have the ability to provide for the patients. I think being ready for concerns from what else is coming from the underpayment or even denials for the patient responsibility side. We saw that a lot in the next gen all-inclusive population-based payments where our payment to our providers were spot on. However, the secondary or the patient responsibility side had a huge uptick of issues and concerns. So having the ability to understand that and prepare providers for that will be essential for kind of your ability to manage this capitated payments side of the direct contracting entity.
Okay, great, thank you. And Dr. Gwynn, how do you think the payment mechanisms, primary care or total care capitated payments and advanced payments play into a group's decisions to participate as an ACO or DCE?
Yeah, I think given the different payment mechanisms through direct contracting, capitation being one, and then total cost of care benchmarking and the potential for shared savings as a second value revenue stream, I think it's important to consider both. I completely agree with Rachel, and bravo, Rachel, for jumping into the all-inclusive population-based payment aspect of NextGen. That took guts, and and we watched from afar. I fully agree with you. The market has to be ready for capitation. Primary care, in particular, has to be ready for it. And quite honestly, in my opinion, has to really have had some success in managing risk. You can't just jump into it. You have to have some of the infrastructure already built around population management, enhanced care teams, home-based care, community engagement. There has to be a bit of a track record of success to really take on capitation. We're really looking at primary care capitation and not global at this point, because our market is not ready. The specialists in our market are not ready for us to manage their payment. And so we have to accept that and work from where we're at. Managing risk also plays into performing better than expected total cost of care benchmark. It's the same mechanism, it's the same competencies to really do that well. So if you manage risk well or think you can, capitation actually in the long run will provide more financial benefit.
All right, great. Thank you.
And Sheila, could I just add something?
Yes.
So I would just echo what both Dr. Gwynn and Rachel said, and I would emphasize how important it is to understand your market. Because as both Rachel and Dr. Gwynn said, one market may be ready for capitation, another market may not. I don't know that there's a market in the country that is willing to delegate specialty payments or hospital payments to a third party, as opposed to having those payments come from Medicare. So, I mean, I know as a physician, an independent physician, someone who receives payments our group does from CMS, I don't know that I would be willing to delegate that to a non-public entity, even a small Medicare Advantage plan. So I think even though that opportunity may be made available by CMS, I don't think it takes incredible trust, and I don't think there are too many markets in our country where that is going to happen. On the primary care side, I think the beauty of the Medicare Direct contracting proposal is that it gives the direct contracting entity authority or the flexibility of paying its physicians capitation or paying them on a fee-for-service basis based on historical utilization and current utilization. So that in our community, where many physicians are still not comfortable with primary care capitation, that's what we've actually chosen to do in an effort to enhance the number of attributed lives that we will have. That being said, you also have to know, I don't think you can just jump into this without having been an ACO and understanding utilization. Because if we look at the utilization amongst our physicians, it's across the board. I mean, it varies dramatically. And so we have to be the ones that are going to manage the fee-for-service payments or the capitation. And we've taken it upon ourselves as the entity to take on all that risk and to basically accept all the risk on the upside and the downside, if that makes sense.
Absolutely.
Sheila, if I could add to that as well, and I really appreciate those comments, Dr. Delagdish. I think that's right on. In our network, in one of our employed networks, we've been utilizing what we're calling a shadow capitation model for several of our primary care practices over the last year and a half. It's pretty remarkable how quickly care delivery can change when you're capitated. The movement to virtual care, even pre-COVID, hiring LCSWs and population health personnel, engaging pharmacists differently and better, outreach phone calls. I mean, it really can catalyze change in care delivery really quickly. So I do see this as a potentially catalytic model.
Right, and let me just add one last thing. And we, as a group, have taken all of that upon ourselves, as opposed to allowing the participants to do it on their own. So we have provided them with the population health infrastructure. We have provided them with care coordination infrastructure. We are not willing, because we're the ones that have accepted the risk, we're not willing to allow them to just sort of take the money and run, or overutilize, underutilize. I would use the word underutilize when it comes to, not participating in care coordination or not embracing virtual visits, all the sorts of things that need to be done to better manage care, better coordinate care, and ultimately improve the quality of care and reduce the cost of care.
And all of those are going to be necessary to take into account to be successful with capitation. And that's why CMS, even if you start off with the primary care capitation, the amounts are going to, they're going to start you off with that 7%. And if you go into the total cost of care, they're forcing that increasing amount every year to really think about that redesign. So all great points for consideration. Now, we started on, I think, Dr. Gwynn, you touched on this first, was kind of your benchmark and understanding experience and managing against a benchmark and expenses underneath it. There's two different ways that Medicare looks at creating benchmarks, and I think it's very important to look at both. Direct contracting is using something for the first time. They're going to be using the Medicare Advantage rate book for the fee-for-service population, and they have updated it and released what they're calling the KCC rate book. And the KCC really comes from the Kidney Cares program. And they're going to be using a combination of historical expenses and the KCC rate book in both the professional and global models. And the KCC modification that what they've done to the Medicare Advantage rate book is they have gone ahead and includes hospice expenses now. So that will be included in the benchmark as an expected expense. And they've excluded the uncompensated care. They've also put a floor, which is minus 2% and a ceiling, a 5% ceiling on the rate book on how much that can change your overall benchmark. And it is based upon the USPCC amount. So they're allowing you to use this new blend, but they're ensuring it doesn't change your benchmark more than a certain threshold. They're also including, Medicare is also including the discount factors, which is something that next generation ACOs had, was a discount factor, where they're automatically putting in a 2% and graduating up 1% each year to 5%. So if you're looking at starting in 2022, you'd have a 2% discount, and then it would move to 3% in 2023. And so that means that your savings, if your goal was to save 5% and you're starting off with a 2% discount factor, you really have to be aiming for saving 7%. In the ACO, ACOs use a blend of historical expenditures and the Medicare fee-for-service county expenditures. So they're both using historical expenditures based upon your population, but the differences are they moving in the Medicare fee-for-service county expenses, or are they going to be using the new KCC rate book? And ACOs do not have a discount factor, or what I would call a savings hurdle. So that's a little bit of a difference between these two. So I'd now like to turn it over to our panelists and ask if you have looked at the benchmarks and how it factored into your model selection. So Dr. Gwynn, let's start off with you this time.
Thanks. That was complicated what you just said, and I think it speaks to how complicated this can be. So full transparency, we have actually delayed our application for direct contracting until this next cycle. A lot of that had to do with the COVID effect in our specific market and a little bit of uncertainty. So full transparency. So I actually haven't seen what our benchmarks would be. And if there's anything that I've learned about how to do this kind of work over the past couple of years, it's like real estate, location, location, location. This work is benchmark, benchmark, benchmark. And trying to both predict what a benchmark will be and then trying to predict performance against that benchmark is a bit of an art form. So it's actually, I think it's actually pretty difficult to say what kind of effect all of this will have on our specific benchmark and then really assess what our likelihood of success is. What I can say is it's complicated. And what I can also say is that a 3, 4, and 5% discount is really steep. In the Next Gen program, we're used to about a 1.5 upwards of a 2% discount, and we overcome that, which is fortunate. I would also, I would consider an MSR a bit of a quote discount. There's a barrier there to shared savings that many MSSP ACOs have struggled with. So it's not a dissimilar concept. What I also know is that if you look at the participants in DCE for this upcoming year, many are capital-backed, high-risk care delivery providers who do manage risk well and are used to managing benchmarks that are based on the rate books. So there's a reason they're attracted to this model. I'm going to assume that they have done good due diligence and looking at the likelihood of success and have good financial modeling. What I can say about our particular ACO and integrated network is this is why we built a financial infrastructure and modeling within our shop to look at this. There's a very long-winded answer to your question, and it doesn't answer your question directly, because I really think that this is for every local ACO or direct contracting entity to look at the numbers when they come out and to really really look at this discount factor hard. 5% is extraordinarily difficult to overcome.
Great, thank you. And Rachel, I know you and I have spoken about some of the work that you did looking at your benchmarks ahead of time. How did it factor into your model selection?
I think that you have to look at how the benchmark is calculated and the discounts, whether it's the minimum shared savings rate that Dr. Gwen alluded to, and the discounts that are kind of more spelled out in the direct contracting. You have to look at it all, but I agree with Dr. Gwen on it has to be based on your location, your regional and aspects, and your historical spend. There's no right or wrong answer on going direct contracting or ACO. I think it's really for your ACO, and how that is determined is based on your numbers.
All right, great, thank you. And Dr. Delagish, what have you looked at the benchmarks and how did it factor into your model decision selection?
So, we have not come to a conclusion as to some of the options, making a choice as to some of the options that will be made available. But that being said, we did do a significant amount of due diligence on making the decision to move from an ACO to the direct contract. And unless, well, I could certainly be mistaken, and as I've stated previously, this is somewhat of a moving target because CMS keeps changing the rules, and those rules can have dramatic financial impact to contracting entities or to ACOs. And it's my hope that this program will enhance fee-for-service medicine and provide patients with more choice and provide physicians with opportunities to better manage risk and not leave 15 to 25% of that shared profit or profit per se on the table for the Medicare Advantage plans. We all know that Medicare Advantage plans cost the government more than fee-for-service Medicare on a per beneficiary basis. My hope is that patients will, that this program will allow CMS to compare the two programs and hopefully see that there is a continued role for fee-for-service Medicare and not outsource the entire program as they have, as they did for Medicaid and to many of the Medicare Advantage programs. So that all being said, we did do a thorough investigation and due diligence, and we believe that this program is going to be far more beneficial to our organization than our MSSP ACO or as compared to many of our Medicare Advantage relationships. Whether or not that is the case, I think it will clearly force us to, there's nothing more that pushes you more than being at risk. So once when you're playing with house money, it's one thing. When you're playing with your own money, it's a whole different story. We are not, as Dr. Gwynn suggested, we are not, our Medicare Direct entity is not backed by a private equity firm or by a large health system. So we will pay very close attention. We've certainly engaged a lot of consultants to help us, and we do have our experience as an ACO. So we think, and we have taken full risk with Medicare Advantage plans, and we think that gives us, we've been doing that for 20 years, we think that gives us hopefully enough experience to be successful in this program. If we are not successful in this program, it likely means that many other entities won't be successful in this program. As was the case, as in the case I mentioned earlier, I think with Pioneer ACOs and even the ACO program itself, the fact that such a small, in my opinion, percentage of ACOs were able to generate shared savings is a problem, not just for the ACOs that weren't able to generate shared savings, but a problem for CMS. And hopefully CMS and CMMI have learned from that experience to make the Medicare Direct contract, the MDEs, more successful from those learned experience under the ACO model.
All right, great. So lots of considerations then for people considering whether or not to look at direct contracting or ACO. So looking carefully at your benchmark, looking carefully at if you're an ACO, at your ACO reports, because a lot of the quarterly reports and annual reconciliation reports will provide some critical input data into doing some modeling for benchmarks. Good to look at both benchmarks, as Rachel said, as Dr. Deligish said, very important to have that experience taking risk and really being prepared for that. And then, as Dr. Gwynn said, you have your discount factor that you want to think about as kind of your hurdle to your minimum savings rate, but really look not just at how much potential savings could be earned in year 1 and 2, but really look all the way through that 5 years to understand how that discount factor plays in as you look over at the models that I have looked at and I've worked on. We look at all 5 years for that reason, because you really want to understand at the end of that 5 years what that nets out to look like in both ACOs and in the direct contracting. So Dr. Deligish, you talked a little bit about some of the opportunities to better coordinate care in the direct contracting model. And what we can see is CMS is offering, or CMMI are offering additional waivers and benefit enhancements beyond what we originally saw in the ACOs, because in the next gen, CMS included new types of benefit enhancements, as they're called, instead of just waivers, that started to include the care management home visits, chronic disease management report, and some of the cost sharing support for Part B services. Now, in the direct contracting, CMS has proposed 3 new types of benefit enhancements. So one of them is allowing home health services certified by nurse practitioners. I've heard people talk about that as a good expansion of benefit enhancements, and I've heard some people raise concerns it's going to increase the amount of home health that is prescribed. CMMI is also offering the opportunity to prescribe home health with waiving the homebound requirements that's traditionally hand in hand with home health. And then they've also are proposing the concurrent care for beneficiaries that elect a hospice benefit, which is why we saw the change that CMS made in September into the direct contracting financial model by including the hospice expenses. So there's a myriad of benefit enhancements. There's 9 altogether, and that's including the standard Stark and antitrust waivers that are part of the program as well. And CMS is saying they're newly proposed because they have to go through all of the standard approvals that are required, but CMS fully expects those to be approved. So the question for our esteemed panelists is, how are you either planning to use, or how have you used either waivers or benefit enhancements in your ACOs, your next gen ACOs, or are you thinking about using them in direct contracting? Rachel, let's start with you this time.
So at our ACO, we actually have only used the 3-day SNF waiver, even though we have many of the other waivers available to us through NextGen. Just with timing and everything going on, especially the claims payments, we have not dived deep into the other ones. I think the 3-day SNF waiver, as I'm sure many of you all agree, that it's a very beneficial waiver that can really coordinate the care to patients needing the level of care needed and not having to just go to a hospital and stay 3 days to get that care that is truly needed. So I think that's really the only one that I can comment on. I have not, had efforts into implementing those other ones, but definitely with COVID, a lot of home delivery has definitely changed. So I think that is something that our ACO is definitely looking into, more home visits, and that may come into play next year as well.
Okay, great. And Dr. Deligish, have you used waivers in the past or benefit enhancements in your ACO or direct contracting model? And what are your thoughts about using them in, I should say, have you used them in the past in your ACO or NextGen ACO? And how are you thinking about using them in direct contracting?
Well, we've not, since we were an MSSP ACO, we weren't able to take advantage of the waivers, but we still were able to implement telemedicine, chronic disease management, and telehealth. We have also taken advantage of managing patients through a post-discharge home visit program, but we haven't had any waivers, used any waivers because of our status. In direct contracting, we plan on taking advantage of as many of the waivers as possible. Our direct contracting entity has a contract with a very, very large home nursing company to assist us. We have contracted with a skilled nursing facility. We've contracted with hospitals. And so we, despite the very short period of time that was provided to us by CMS, we were able to contract with over 1,000 physicians and 7 hospitals in our geographic area. So both specialty hospitals as well as what I will call primary facilities. So we're very excited about the opportunity to implement many of these programs and are pleased to see that Medic CMS, after 20 years or maybe 10 years, 12 years of since CMMI was essentially began this journey, has started to make these programs available or more available through the waiver program.
Okay, great. And I should have started with this in the beginning. Your group is on the east coast of Florida in the Melbourne area, is that correct?
Yes, we are in essentially our primary network. Our participants are all in Brevard County. We wanted to limit it to our geographic area, so that's a 72-mile span: Melbourne, Palm Bay, Cape Canaveral, Cocoa Beach, Kennedy Space Center, and Titusville, about an hour from Orlando. Our specialty hospitals are the Cleveland Clinic south of us, rapidly moving up the coast of Florida, and we have hospitals in Brevard County as well.
Okay, great, thanks. And Rachel, you're located in Central Florida, so you're in the surrounding Orlando and surrounding area.
Correct. More North Orlando, Villages, Mount Dora, basically the section between Gainesville and Orlando.
Perfect, great. And then Dr. Gwynn, you're coming to us live now from North Carolina, and your network is across North Carolina as well, right?
That is right. And I used to live in Fort Lauderdale, though, so I have some Florida roots.
That's great. That's great. And so what types of waivers have you used, or what type of benefit enhancements have you used, and what are you considering for direct contracting?
I think we've taken advantage of several of the waivers pretty well, and not dissimilar to Rachel. The 3-day SNF waiver has been highly effective, and not just for limiting the need for hospitalizations, but we've actually used that waiver to coalesce a number of SNFs in our region into a preferred SNF network. We use that as kind of the carrot to attract some SNFs, and now we've really started working on good care coordination and care pathways for COPD, CHF, and others. So really getting at, we've used it to leverage savings and total cost, but now to really build on good care coordination and care redesign. We're a rural state. We've used the telehealth waiver in some of our rural areas for telebehavioral health with LCSWs and other behavioral health providers. Surprisingly had really good uptake from our elders living in our rural counties. So that was actually really beneficial and something we learned a lot about how to administer telemedicine through that. We've had limited success in the post-discharge home visits for lots of reasons that we can spend probably 30 minutes talking about. It's just not a great waiver. And the cost sharing support we tried as well and just didn't get a lot of uptake from it. So I'm really pleased that that CMMI is continuing these waivers and adding additional ones. We really see the role of centralized teams like this, like an ACO or an integrated network or a DCE, not just to reduce total cost of care, not just to improve quality, and not just to redesign care, but also decrease the administrative burden of our providers and frontline care teams. And managing home-based care centrally is a lot more effective and efficient than requiring physician orders across the board. So am I a little concerned about increasing cost and home health orders being written? Maybe, but I don't think so. Actually, I think we're going to be able to manage it a lot better centrally and reduce the burden, the administrative burden on our docs, which I think is really value add. The ability to provide hospice and palliative care in the community in homes is really beneficial. We just launched a community-based palliative care program, and this type of waiver, I think, can really help us move that along more aggressively than we would have otherwise. So I think these are positive moves.
Okay, great. Well, I know we are at the end of our session. We have 3 minutes left, and so I'm going to ask as a final question, since a group has to choose whether or not to go direct contracting or an ACO, because providers and that TIN cannot be in both models. If you could each take a minute and just leave us with kind of your thoughts on what consideration you'd offer someone looking at these two models. Dr. Quinn, we'll start with you.
Oh, sure. It's interesting. We're actually looking at participating in both across our network. We're carving up our network to participate in direct contracting and likely MSSP enhanced. And we're trying this out. This is a bit of a test to see if our market is ready for capitation. So I know we talked about that a little bit before. So I think my advice would be to really assess your ability to manage risk. And if you have a track record of doing that well, have the right infrastructure in place, or can align with an organization like Dr. Delegish's who has managed risk really well, then direct contracting might be the right path forward. I think in the long run, there's likely more financial upside and likely the ability to catalyze care redesign faster, but there's clearly more risk, and the details of the financial model really matter, and the change in the quality measure set through direct contracting is significant, and that really matters too. So just like it's been advertised, it's higher risk but potentially higher reward. If you think that you're not quite as far on the path to value, on the road to value, then considering a traditional ACO may still be the right option to build your capacity to manage risk better in the long run. I know that's a high-level recommendation, but I think that's about right.
Okay, great, thank you. And Rachel, 1 minute or less, what would you leave as a final consideration for groups?
I think I'll touch on the contractual payment arrangements, the ability for direct contracting to have the ACO or direct contracting entity build a preferred provider network is going to really drive down utilization in the long run. Be able to build the relationships with those providers, and basically just gives you another tool to help kind of drive your coordination of care. and making sure that you understand all the financial benchmarking and the total care capitation or the primary care capitation of not only just from the financial perspective, but the operational side of it, from a billing perspective, will really help direct contracting entities' ability to perform.
Okay, great. And Dr. Delegate, what would you recommend?
So I would just in a nutshell say that I think that this is one of the most significant advances in payment models in the last 25 years, probably the most significant. I think it gives physicians control. It gives physicians the opportunity, as I think one of the things that we neglected to focus on, maybe not purposefully, but Dr. Gwynn brought it up, is the reduced administrative burden that this program as an APM, an advanced payment model, provides for primary care physicians. No more having to, some of the administrative burden associated with MIPS and MACRA is no longer, we've been relieved of that. And so that is a significant issue. And by being relieved of that, that gives us more time to focus on taking care of patients and doing the things that this program allows us to do. So as Rachel said, the ability to essentially subcontract with preferred providers to include hospitals, laboratories, skilled nursing providers, hospices, that gives us another sort of, I don't want to use the word weapon, but another tool in the toolbox to reduce cost and to mitigate the risk that's associated with this model. And in doing so, CMS has provided these entities with essentially an insurance license. And I think that's where, if this program is managed properly, and it really gives us something we never had before, and hopefully the experience of Pioneer ACOs, Next Gen ACOs, MSSP ACOs will help providers, physicians, other entities to do a better job in this model.
Well, that's great. Well, I thank everybody for your input, and I thank our attendees for all the questions that have been asked. And this has been a great session. So again, thank you, Dr. Gwynn, Dr. Delegash, Rachel, for your participation on the panel. I think there's been lots of good discussions on the pros and cons of whether or not to go into direct contracting or looking at the ACOs. And we wish everybody the best in moving forward with their decisions. And I wish all three of you the best in your participation in direct contracting. So thank you.
Thank you, Sheila.